Good afternoon. Today is Thursday. I wish it was Tuesday. Thursday, April 27th. It is 12:32 p.m. and I will call to order the April regular meeting of the Spokane Regional Health District Board of Health. If we could take a roll call of members present to establish quorum, we'll begin with Mr. Dorona.
Alicia Policani, present.
Kevin Freeman, present. And then telephonically, I believe we have Commissioner Kearns. So let the record show that we have a quorum of board members today and may conduct business. We also have present here today Dr. Velasquez, our health officer, Lola Phillips, our deputy administrative officer, Michelle Fossum, board's legal counsel, and Ann Pittsnoggle, recording secretary. At this time, I would look to see if there are any board reports, which I will begin with my chair report. Want to give the board an update on the recruitment process for the administrative officer. We have received greater than 3 candidates that we feel are responsive and considerable for the position. We are looking to keep the recruiting open until the end of this month, April, but at the end of April, before the next executive committee of the Board of Health, so the executive committee for the Board of Health, the executive committee will review the responsive resumes that were that will be brought forth by the recruiter, and based on the exec committee's review of those resumes, we will determine a pool of candidates to be interviewed for the position. So hopefully by the next regular board meeting, we will be coming to folks with a schedule of what we see for future events for interview and hiring. So that would be also at the time when we would look at how we want to make candidates available for internal stakeholders, external stakeholders, employees of Spokane Regional Health District, etc. So I hope to have that back to the board at the next regular meeting. One thing I would like to call to your attention that is in your packets is a handout here for the North American, what does NACHO stand for? I don't remember. Ann, what does NACHO stand for?
National Association of Cities and County Health
Organizations. So this is the national conference for health organizations, health jurisdictions, things like that. Commissioner Waldrop has expressed an interest in attending. I am looking at attending and would, Ms. Phillips will be there. I'm looking at attending, but if there are any other board members that wish to attend that, the conference will be held July 10th through 13th in Denver, Colorado. Any travel arrangements would be made through Spokane Regional Health District, but if we do have more than 4 individuals attending, then it is a quorum, and so we would have to note that up as a special meeting. So if there are any of our representing citizen members that wish to attend, or if Josh, if either you or Mary wish to attend, if folks could get back to me on that, and then we can kind of look that over and see. I think it would probably be best if we did not have a quorum attending. That would be a weird setup of a special meeting, but for individuals that are interested in attending, please reach out and we can work something out at that point. And that's specifically speaking to board members. So any questions on that one, Josh? Okay. And so that concludes my my chair report for today. One last thing. We did have a presentation I attended with our opioid treatment program director, Misty Challenor. There was a presentation in front of the briefing session at the Spokane City Council regarding relocation of the OTP program from this building to 8th Street. That, I think, went very well. The council had some questions for Misty. We were able to make the points. There was a handout prepared for City of Spokane. That was being emailed to the board members here, and we'll make sure that that is available for other folks as necessary, but did want folks to be able to see that. It kind of described the why, the how we got to where we were, what was involved, and where we are at in the process. So right now, it looks like we will be having the, working with Washington State Department of Health to have the relicensing public meeting, hearing here in the future. They schedule that, and they will keep us involved. So that concludes the chair report for today. Committee reports. The committee report was Budget and Finance. Budget and Finance reviewed at that committee. We reviewed the vouchers claims for this meeting today and found nothing out of line. And at that time, the recommendation was determined to recommend to the full board that the vouchers for March be approved and approved for payment. And that concludes the executive report and the budget and finance report. Are there any questions for me on those items? Thank you. So that brings us to our consent agenda today, consisting of the meeting minutes for the March 30th regular meeting and for the vouchers for March 2023.
Sorry,
yes.
Kevin, I do have one. Is there a date or a time that you would need to know if someone's interested in going to? Is there a cutoff date or anything that
Maybe by the end of next week.
Okay.
It's kind of because we've already blown the early bird. No, when's the early bird registration?
The early bird is May 3rd, so if you can let me know by then.
Okay,
Before then.
so yes, there is a cutoff date. It is May 3rd. So, thanks for that, Charlie. Appreciate that. Yeah, so let us know by May 3rd. So we're in the process of the consent agenda, meeting minutes for the March 2023 meeting, and the vouchers for March 2023. Would any member of the board like to take either of those items separately for consideration? Not seeing or hearing any move to that. So at this time, do I have a motion on our consent agenda today as presented?
I'll make a motion. I'll second that.
Moved and seconded. Are there any questions on either the minutes or the vouchers? Seeing or hearing none, all in favor, aye?
Aye.
Any opposed, no? Hearing none opposed, no. The ayes have it, and the consent agenda is approved unanimously today. Thank you very much. Item number 5, executive session. I don't think we need one. There is no executive session today. So this brings us to item number 6, our action items for today, which is Resolution 2302. This is a resolution amending Resolution 2209 to correct expenditure authority for the 2022 Spokane Regional Health District General Fund budget as approved at the December 1st, 2022 Board of Health meeting. Kim, do you wish to speak to that? So Ms. Kramer, as our financial controller, will take this. Thank you.
So thank you for the opportunity to bring this to your attention. The original resolution, that we did 2 resolutions last year to amend our budget. Historically, we have done 1 resolution annually. So essentially what occurred is the first resolution, we took the original budget and then asked for an increase of 4 million, and so we had 51 million as our revised budget. Well, towards the end of the year, December 2022, brought forth a second resolution, but unfortunately, my number did not come from the 51 million, which was the revised. It came back from the original. So I'm just coming forward, this is a housekeeping, that our original budget started at 47 million and ended at 53 million. And the resolution that was done in December had the wrong ending number. Both resolutions were accurate to the extent of the increase that was asked. And so I just want to bring that to your attention and get approval for the adjusted ending budget number for 2022.
Are there any questions for Kim on this? She did present this at the Budget and Finance Committee. We reviewed everything, and nobody likes a Scrivener's error in their resolutions, but that's pretty much what it amounts to. As she said, there is no true financial impact to the district at all, so we just need to correct this in the records. So, any questions for Kim?
And it was in preparation of doing our 2022 financials that we discovered the mistake.
So at this time, I would ask the board if there is a motion on Resolution 2302 as presented.
I'll make that motion.
I'll second it.
Moved and seconded. Any discussion? Seeing or hearing none, all in favor, please say aye.
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 Are there any opposed? Say no. Hearing no's, that motion, or the Resolution 2302 is approved unanimously. Thank you very much. And so that concludes our action items for today, and that brings us to our reports. Our first report is a legislative report that I asked Mr. Bannister to prepare. I know he has some other things, but this is an analysis of Senate Bill 5536 as it was left before the end of the regular legislative session, but this focuses primarily on the public health aspect.
My apologies.
That's okay. As long as you're okay.
Good.
All right.
We're aces.
As opposed to items related to criminal justice. This is more of a focus on the public health aspects. So, Brandon, please take it away.
Yes. Would you like me to start with the briefing on 5536, or just kind of go through things as I had them prepared? I wanted to do a little bit of a session wrap up for you folks, going over some bills that impacted some of our policy priorities, as well as some operating budget items as well.
Please,
Happy to start wherever.
you run as you see fit and how the slides are queued up.
You got it. So regular session ended on this last Sunday, April 23rd, at about 10 o'clock. After session ended, Governor Inslee and Democratic Caucus leadership had some media availability, and they alluded to the idea that there would be a 30-day special session incoming to address SB 5536, which I will be providing some analysis on soon. So if you turn to your bill tracker document, we can go over some of the BOH policy priorities that passed and ended up failing as well. First, we have 5365, which is regarding preventing use of vapor and tobacco products by minors. So big win for lining up some of the statute inconsistencies that are around the 21 age parameter for vapor and tobacco products. I believe it was 18 and 19-year-olds who were not getting penalized, while 20 and 21-year-olds were, or excuse me, the reverse. 20 and 21-year-olds were not getting penalized, while 18 and 19-year-olds were. So clarifying some statute there. And then we also saw SB 5367 pass, which is on the second page. So that would redefine THC products to include synthetic THC and derivatives of THC, like Delta-9, into the statute definition of THC products. This was something that we found to be a public health priority because there's been an uptick in some non-502 licensed stores selling these THC derivatives, synthetic THCs at places like gas stations, and so kids have been able to get their hands on them and ultimately get high as a result. So great, happy to see that was passed. Next we have HB 1255, which if you turn to the third page, you will find it up there at the top. This would create a program that seeks to reduce the stigma and create incentives for healthcare professionals to participate in substance use disorder monitoring and treatment programs. So just educating our healthcare workforce on some of the nuanced methods for taking care of these kinds of individuals. I believe there is some appropriations in the bill for this voluntary program. Next we have HB 1004, which is back on the first page at the bottom. This would install signs on or near bridges to provide information to deter jumping. This was one of the recommendations from Suicide Spokane that also made it into our legislative priorities for 2023. So some great wins. We saw a few losses though. First, we have SB 5022, which is found on the, fourth page, I believe? No, sorry. Excuse me. So it's not on the legislative tracker because this policy was in regard to exempting fentanyl test strips and other drug testing equipment from the drug paraphernalia definition. That policy ultimately failed to pass the House Rules Committee because it ended up being bundled into SB 5536, which we'll be discussing later. So just kind of did some shuffling there. Next we have SB 5580, which we can find on last page, yes, thank you. In regards to improving maternal health outcomes, that bill just didn't end up making it out of the House Rules Committee before the end of session. I'm not sure of the politics behind that, so that one's a little bit of a mystery for me as to why it didn't end up passing. And then we have HB 1006, which you can find on the, I believe, second page? Yes, top of the second page. And this is again, part of SB 5536, so just another measure regarding the expansion of access to drug testing equipment. So that leads us to SB 5536, which is the remedy policy for the Blake decision that was decided by the State Supreme Court in 2021, 2022. There was a bill passed to quickly remedy that legislation or that decision, which is set to sunset, I believe, in July. So SB 5536 was supposed to be a permanent solution to all of the issues that came about as a result of the Blake decision. The bill ultimately died. There were some pretty critical or pretty fundamental differences between the House and Senate versions of this bill. In your packets, I have provided you with the Senate bill report and the House bill report for their respective versions. And I would say probably the primary point of disagreement between them was how they defined methods for vacating someone's possession of a controlled substance charge. A lot of the language in this legislation that pertains to some of the work we do here was pretty uniformal in both bills. So switching gears a little bit, if you want to stay on the legislative tracker and flip to the fifth page, I've outlined a majority of the budget provisions that were found in the state operating budget that ended up passing. Pretty much all these provisions have something to do with public health or a direct impact on our functions here. So primarily we have a total of $324 million over the next biennium going towards FPHS investment. I remember that Mayor Freeman was a little bit concerned about how those dollars are allocated. So I looked into some of the legislation around, how FPHS dollars are allocated. And there is an FPHS steering committee that is comprised of LHJs, the Washington State Public Health Association and their representatives, as well as a couple other key stakeholders, and they basically have to come to a across-the-board agreement on how all those dollars are allocated. Department of Health is part of that group, for note. And then that money is given to the Office of Financial Management for disbursement. So, organizations like ourselves and our associations who represent us do a pretty good job at trying to fight for allocations that they feel we desperately need. So moving on, we have $20 million in COVID-19 response monies. This would go towards the Coronavirus State Fiscal Recovery Fund at the Department of Health. Then we have $72.8 million to the State Treasury for disbursement to County Public Health Services. This would reach counties and health districts in amounts designated to support public health services and include public health nursing. We also found $2.3 million for the Birth Equity Project, which would work towards initiatives that support prenatal and perinatal health with a focus on culturally appropriate, community-led, evidence-based projects that enhance health and parent social support for communities experiencing the most extreme perinatal health disparities. The legislature also appropriated $9.5 million for home visiting programs. This was something that we were talking about during the design process of the board's legislative priorities. We were kind of waiting on reports from DCYF about costs for the home visiting programs and whether those would increase, decrease based on the work that's been done for them. And so I believe that DCYF ended up having plenty of conversations with the legislature about the costs associated with home visiting, and so they were able to get granted some funding for this program. And then moving forward, we have $2.8 million granted towards child health promotion systems, which would maintain the child profile health promotion notification system. We also saw $44.5 million to the general fund for crisis system enhancements. So this would be appropriated for expanding mobile crisis team capacities and mobile crisis services to calls received through the state's new 988 suicide and crisis lifeline. We also saw provisions for extreme weather events. So this was a piece of legislation that I had been tracking throughout the legislative session. It ended up failing, but it looks like we did get some funding for grants to assist local governments and tribes with the costs of responding to community needs during certain extreme weather events. So not a complete win, but definitely better than nothing. Moving forward, we saw there was $6 million granted to the Department of Health around food security measures. Particularly, this would expand WIC's fruits and vegetable program. Another piece of legislation that was notably passed was the Medical Reserve Corps bill, and then there were appropriations of $895,000 for it. So this would go towards the military department and the Department of Health for implementing HB 1452, which should be on the tracker. Let me check. Yes, it's on the top of the third page of the legislative tracker. So a little bit of a status update there for you. We also saw $5 million appropriated to tobacco prevention and control for ongoing maintenance and operations of the Universal Developmental Screening Program. There was $2.8 million granted to the Child Health Promotion System to maintain, we already went over that. Moving forward. There was $1.8 million granted to the Department of Health for school-based health centers. This would go towards establishing new school-based health centers and to add behavioral health capacity to existing centers. There was also $24 million of the Model Toxics Control Operating Account granted towards local solid waste financial assistance grants. This would provide grants to local governments for the purpose of supporting local solid waste and financial assistance. So those are some of the highlights from the operating budget. I unfortunately haven't gotten a chance to dig into the capital budget yet. However, from my talks with the Washington State Public Health Association and the Association of Local Public Health Officials, there wasn't a plentiful amount of capital investment that was given towards public health. Much of that investment was included in the operating budget. So that's how everything has been going on the legislative front in regard to the BOH's legislative priorities, some bills that impact some of our work, and funding that goes into all of that. So moving forward, Mayor Freeman asked that I provide the board with a brief on SB 5536, which is a very large bill that has a wide range of implications around substance use disorder and possession charges for controlled substances. So I will be speaking directly to the provisions of the bill that impact the work that we do here at SRHD. So just a broad introduction, SB 5536 relates to justice system and behavioral health responses to those experiencing controlled substance use disorder, counterfeit substances, legend drugs, and drug paraphernalia, those caught by law enforcement with such drugs. And this was created to serve as a permanent solution to the State v. Blake Washington Supreme Court decision of 2021. The legislation that the legislature passed after that decision was SB 5476, which is set to sunset in on July 1st. So the hope this session was that they would be able to pass permanent remedies for the Blake decision through SB 5536, but alas, some issues came about. So as I had previously stated, the House and Senate versions have some pretty fundamental differences, and the primary points of discussion for this bill. However, the provisions in the bill which largely impact the work we do here are pretty uniform across both versions. And because of this lack of passage, that is why the governor and Democratic leadership alluded to a 30-day special session. So we expect that they will probably get pulled back here in like a week or two to work on this bill and hopefully stay focused only on this bill, and hope it doesn't become a free-for-all for all kinds of legislation that is sitting in the Rules Committee. So the primary provision that relates to our work is around pretrial diversion. So this would set up a program that allows folks to opt for treatment for substance use disorder and substance use treatment in lieu of being arrested or charged with a felony or a gross misdemeanor, depending on which version you are speaking to. So the Senate version has language around requiring courts to vacate convictions of possession for defendants who successfully complete required SUD treatment and file proof with the court, while the House version states that the court is required to dismiss a defendant's charges for a qualifying drug possession offense if the defendant successfully completes pretrial diversion and they are vacated a person's conviction for a qualifying drug possession offense if the person substantially complies with recommended treatment or services for 6 months or complete court-ordered community restitution as an agreed condition of probation. So this is pretty important. Misty and her division can attest to how ambiguous the idea of successful treatment can be for any given client. So the differentiations between the Senate language and the House language is pretty stark. The Senate version would leave a lot of subjectivity out for what is not outlined as far as authoritative entities to decide. So we can surmise that might be courts or potentially any administrative rules that clarify that going forward. While the House version has a pretty specific definition for how someone can get those charges vacated, specifically by complying with recommended treatments for at least 6 months or completing court-ordered community restitution should it be an agreed condition of probation. So this creates some impact potentially for increased caseload for our treatment services division. It is very, very difficult for any of us to accurately estimate what that increase in clientele would look like over any given period of time. However, treatment services does already handle clients who have been court-ordered to seek substance use disorder treatment, so they are very privy to all the reporting measures that are involved with the courts and that process. So another key provision of this bill that's found in that you can find in Senate Bill Report 5536, page 9, is language around streamlining SUD treatment intakes. So the language goes, HCA must convene a work group to recommend changes to intake, screening, and assessment for SUD services by December 1st of 2023, with the goal of shortening the intake process and broadening workforce capable of processing the SUD intake. So this was a pretty key provision that was found in our legislative priorities around addressing the efficiency of administration for some of our programs. This could have the potential to greatly accomplish that goal. Currently, OTP intakes can take up to around 4 hours. So in regard to the recommendations for intake screening and assessment changes, we are totally open to any bit of help on that front. The HCA work group that would decide these recommendations would consist of care providers, payers, and people who use drugs, as well as other individuals recommended by the Healthcare Authority. So next we have some language around what is considered drug paraphernalia. The language goes, the prohibition against giving or permitting drug paraphernalia to be given is eliminated. Drug testing and analyzing equipment is removed from the definition of drug paraphernalia. Public health and syringe services program staff are exempt from arrest and prosecution for taking samples of substances and using drug testing equipment to analyze substances or detect substances. And this is something that has been a pretty big point of confusion for programs across SRHD. SRHD did do a legal review of the Blake decision after it was decided and concluded that we do have the legal authority to distribute drug testing equipment. However, given that there wasn't clear legislative language around such authority, there was a lot of confusion and apprehension around some of our programs. I know that communicable diseases and prevention were part of the group that did the legal review, so they were specifically aware of their authority to distribute drug testing equipment. However, programs like treatment services and syringe exchange services were a little more apprehensive because of the ambiguity around the ruling and the subsequent legislation. So all to say that the passage of 5536 with this language, which is found in both versions of the bill, would really dispel a lot of confusion across programs about the legality of using and distributing testing equipment. And just having more programs being able to do that can only help our efforts towards preventing overdoses in our community. So moving on, there was a provision around opioid treatment program, rural access, and expansion. There are two key provisions to point out for this very long section. The first regards OTPs and mobile OTPs, who in this legislation would be recognized as essential public facilities for the purpose of local land use regulations, and it would remove the requirement for DOH to hold a public hearing in a community where an OTP is proposed to be located. Cities and counties are also prohibited from imposing a maximum capacity on OTPs. The second key provision states that subject to funds appropriated for this specific purpose, a program is established in the Department of Health to fund the construction costs necessary to start up substance use disorder treatment programs in regions of the state that currently lack access to such programs. This funding must be used to increase the number of substance use disorder treatment programs in underserved areas such as central and eastern Washington and rural areas. So that first provision grants OTPs the status of essential public facilities, which is advantageous for navigating land use regulations at the local level. It would also eliminate the requirement for community forums to move locations. However, that would not apply to our current OTP, given the timing of our move and when this legislation would go into effect. The second provision is a pretty big one because it provides an unspecified amount of appropriations, but appropriations nonetheless, for the construction of OTPs within the greater Spokane area. This would definitely decrease the financial burden on programs like this and increase access to those facilities and the number of those facilities in our area. Moving forward, this was a provision that Mayor Freeman brought to my attention that is pretty cutting edge. So the language around this provision states that the Healthcare Authority must develop payment structures by 2025 for health engagement hubs, defined as all-in-one locations where people who use drugs can access a range of medical, harm reduction, treatment, and social services. Hubs must be open to youth and adults, provide referrals or access to methadone and other medications for opioid addiction, and function as a patient-centered medical home by offering cost-effective patient-centered care, which would include wound care, provide harm reduction services and supplies, and provide linkages to housing, transportation, and support services. Hubs may not be supervised injection service sites. So this is a pretty cutting-edge proposal that really takes a holistic approach to treatment. Services like medical assistance, treatment, medications for opioid addiction, linkage to housing, transportation, and other social services are pretty huge, especially for a population that usually has these fundamental needs not being met in addition to their substance use disorder. In many cases, people have these co-occurring needs. And that's something that treatment services can attest to. And we can also, surmise that in many of those scenarios when folks are having all of those needs met at one time, they see higher success rates of treatment and being able to move on from those substance use disorders. And so some of the barriers that we have around these services currently is that they're provided in varying locations, separate locations that are hard to reach for people in regard to transportations. Folks might not know where all these institutions are located, let alone all of the work and headache that goes into navigating the administrative processes of several institutions at one time. So all those factors create a litany of barriers for that population to be able to access all of their essential needs. So if we can get a single hub together that offers all these wraparound services, we drastically reduce those barriers and challenges while creating great potential for successful rehabilitation for that population. And lastly, there's a couple notes about appropriations that are clearly defined. There is a total of $3.6 million total funds going towards a grant program for arrest and jail alternative programs, and the appropriations for these programs could assist SRHD with our process for intake and working with law enforcement. So a lot of information. Please let me know if you have any questions. I also have Misty Challenor here to answer any technical questions that you might have.
So just a couple things before I open it up for questions to Brandon. I do think that everybody is well aware of 5536 and the lack of passage, primarily from the scope of what it means for municipalities with public drug use, misdemeanor convictions, things like that. My guess is, or my feeling, and Mr. Kearns and others who know far better than I do, is that there probably will be a special session, and there will probably be incredible pressure on the legislators to get something fixed and get something passed that eliminates the need for a patchwork of local and county laws, rules to combat the things that are not being fixed as part of the lack of passage of 5536. So I felt it was important for this board to understand what the overall implications to the district are should this be passed, because it looks like there's going to be a real push to get this passed. So there are some things in there that we should be aware of, particularly with related to substance abuse, drug paraphernalia, OTP, citing. I found one thing that was interesting with regards to the health engagement hubs. There is a small provision in there that says one health engagement hub per 200,000 residents of an area. So we could look in Spokane County at potentially requiring 2 health engagement hubs at a minimum, which that would mean more than likely a second OTP site someplace else that would be part of that health engagement hub. So that's just something for this board to be cognizant about if this is passed. Should it be passed? Because as Brandon said, there's already a lot of concurrence between the Senate and the House on these portions that affect us, that affect SRHD. And so there's probably not going to be a lot of tinkering with these parts as they go forward. I do think that we also need to remember that there is not much money in this bill for all the things that they are asking to do. There will be a lot of things that will need to be done that hopefully some money will be found to assist in these types of things, but law is law, and there doesn't seem to be a lot of fiscal input from the state into carrying these forth. So that ends my soapbox. I would ask if you have questions on the report or on the analysis. Thank you very much. I know this was kind of a short time frame, but I do think that we all know that we all hear all the stuff about drug laws, drug use, drug laws as part of this bill. I did want this board to be aware of there's a lot more in this bill than just fixing the Blake decision. We're going to end up with more things that we're going to have to do here at the district. So I will open it up for questions, please.
I have one. I just want to clarify. So would our current OTP be considered a hub, or would it be in addition to? Because you mentioned 2 hubs for our population.
Yeah, Misty,
Whoever.
we will ask Misty Challenor to come up front.
Yes.
and also answer questions with Brandon there. Thank you.
Misty can definitely speak on her interpretation of this as well, but my reading of the legislation was that this wouldn't require us to become a health engagement hub. I think it offers us the opportunity to become one through, just expanding our services, or even creating a second site and using some of those appropriations that are given for construction. But my interpretation of the text is not one that would see us be required to become a hub and wraparound service provider.
Right, so with our current OTP, we would not be currently considered an engagement hub. If we were able to expand services, within the new location and be able to offer more of those services that they call out in the bill, then that might qualify as, I don't know if it calls out specifically that there has to be specific licensure or identification that specifically calls out the facility as a health engagement hub. But with the expansion of service, the potential for expansion of services at the new location, that could potentially be an option that we would be able to move towards. But again, not knowing what the requirements are for that, we are not currently considered an engagement hub in that capacity. Absolutely. That's actually one of the things that I was excited to see that they had in here was, without the specifics called out in here, the fact that that's one of the biggest barriers that we see in it as a community is that when we've got an individual that's needing services, they may have services within 6, 7, 8, 9, 10 or more different facilities, and it's just the transportation being a big factor with that. And then having the individual follow through with being able to get from point A to B to C, 1, 2, and 3. And then in addition, if they've got children and then there's childcare issues, and being able to navigate those systems. So having all of those services centrally located within any one location is going to be advantageous to the population.
A bit confused, just to clarify, because I might have missed it. Sure. If the pass of 5536 happens, would we be required to open up 2 hubs or so, or is it just an opportunity?
No, we wouldn't be required, and I think that goes back
For the
to
community.
Ms. Polakani's question. We wouldn't be required to do so, but it would offer us the opportunity, and there would be potential funding for construction costs of that facility. Yeah.
Thank you.
No problem.
Any other questions? Mr. Kearns, do you have any questions out there in telephone land?
No, I mean, I really appreciate the rundown, because it was more the criminal side that got the most attention when people spoke of this bill. It was more on, is it going to be a misdemeanor? Is it going to be a gross misdemeanor? And it seemed that that's what sort of the rub came down to when you looked at the breakdown of the yay and nays. And I'm going to be it'll be very interesting to watch and see. I mean, there were a number of members of the majority in the House that crossed over and voted against this in the end, because, and they were very honest that, they're looking at sort of decriminalization of drug use. So it's going to be fascinating to look and see how they're going to be able to cobble together 50 votes in the House to get this over the finish line.
Thanks, Josh. We appreciate your insight on that. Any other questions? Any closing comments from either of you?
No, I guess I would just, end my presentation by saying, I think that there are so many beneficial aspects to SB 5536 that really get at the heart of, the issue, which is substance use disorder, and how we move folks out of that disorder and into successful treatment. Because I think if we can do that, and we can do that on a wide scale, we will end up seeing less controlled substance charges. So while there's a huge sticking point on the degree of penalty for possession charges, I think this is a pretty positive bill overall, especially as it relates to the work that we do here.
Excellent. Thank you both, Brandon. Thank you very much. Misty, thanks for answering questions. So that brings us to our financial report today. Ms. Kramars, would you let us know where we stand?
Okay, so I bring 2022's final numbers to you. That should be in your packets. In addition, we also have the March 2023 report. So I'd like to start with 2022. And as I discussed earlier today, we did have 2 budget amendments in 2022. So our final revised budget for 22 was $53,182,411. We did end up with expenditures of $47 073,836. And then revenues were 48,972,414. So we have a significant increase to our fund balance for 2022. The amount of being 1,898,578. That is not expected to continue. There's several factors that brought this to fruition. A big part of it is we still continue to have COVID funding to help offset some of our local dollar projects that wouldn't have otherwise had any other funding stream. And we also received an increase in some FPHS funding that helps in the reinforcing capacity that also offsets some local dollars. So this is a good opportunity for us to set aside some funds in our assigned reserve. So in the lower section, each year we'll do an evaluation based on what we have in reserves, and always account for having a board emergency of $1.5 million. We want to keep our unassigned reserves at least 20%. That's important. State auditors will look at the financial liquidity of the health district and our stability. And so they like to see at least 2 to 3 months of operating expenses in your unassigned reserve. So we like to keep that at that 20%. But now with having an increase in fund balance to carry forward, we have set aside in assigned reserves, and that is management's intention of how we would utilize these funds at a future date. They may not all happen in '23, but these funds are set aside. They can also go back into the unassigned reserves if they don't come to fruition at the dollar amounts. So I'll just go through those real briefly at the bottom here. The first one is the building. So the health district received this building from Spokane County a few years ago. And so it's prudent to always have a savings account for those unexpected building improvements that may arise. In addition to that, we've now established a building reserve for ADA. There's an ADA compliance audit that comes through, and there's some modifications to our building to be up to the latest code. So we've set a reserve aside for that. Additionally, you may have heard about the Clean Buildings Act. Several buildings, based on the age, have energy improvements that are needed to be in compliance. I believe it's by 2027 is the rollout. So this is establishing a reserve fund to go towards those improvements for this building. We've also established some information technology, our IT area, some infrastructure of $195,000. So there's some resources that we have been needing. So setting aside funds there. And then we get into the Environmental Public Health Division. Anytime they're permit based, and so anytime their revenues exceed their expenses, we set aside the difference into reserves. And then we monitor that, and we can make modifications to future permits if we need to, so that those funds are specific to that program. And that would be true of solid waste, food, schools, and water rec. Then also we've established a $500,000 reserve for treatment services for a new electronic medical record replacement software system that's been needed. That's going to be a large endeavor in addition to a move. So we're setting aside some funds towards that. And then the last one, treatment services reserve, is continuation of our relocation for this year. So any unspent funds will go back into the unassigned reserve, but this is a placeholder. We had relocation funds set aside in '22. We're carrying forward some of those into '23 for the official move that happens this year. So that brings our total reserves for 2022 to $16,700,365. And overall, our budget, we were at 88% for expenses and 92% for revenue. Does anyone have questions on 22?
I'll just say a couple things that we have discussed at the executive committee level. The building funds, we are lucky to have those because we do have things that we need to do. And as we know, we did make the ask for APA, ARPA monies from the county that we did not get all of the ask that we made for building improvements, capital improvements to the building. So those needs were previously identified, and now we do have some reserve set aside for those, so we can begin on that work. Also, for the treatment services, EMR or EHR, electronic health records, that project needs to be done. It's our understanding that we have some things particularly related to treatment services that our current system does not account for, and we need to correct those. And so a new EHR is vital. There's also going to be, as was explained to me, some overlap because we will have to run two systems at the same time for a bit while we cross over to the new system. So it would be a good idea to provide treatment services some clarity as to what they're going to be doing once they get to the new facility. So we know we have folks looking at quotes, RFQs, RFPs for a new EMR, and we can go forward from there. One of the last things in treatment services is because of the EHR, we have a plethora of paper records that have to be stored securely because of HIPAA, everything like that. So one of the things that we have talked about is rather than burden treatment services by taking a bunch of paper copies over there, we need to get started on a digitalization project for those records. That has to be done in compliance with HIPAA because they are patient records. So we have some folks in treatment services looking at what that will take to get those records digitized in such a way that we are not moving a bunch of records over there that we could potentially get digitized, storing them, and then taking them somewhere for destruction or long-term storage. So I have asked treatment services, along with everything, they just have a few things going on with a move. So we've dumped electronic medical records on them and a digitization project on them. So it is good that we have had this, I won't call it a windfall, but as you said, Kim, this one-time ability to realize some extra reserves that we can target for projects that we either knew we need to have to do on the capital side, or make sure that our treatment services program is fully compliant, running, everything like that. So if there are questions on 2022 where we stand, I would direct that to Kim.
And I'll just add too that it does take a process to close out the year, so I know we're almost into May and I'm reporting 2022. But we do keep the books open for 3 months for any 2022 expenditures that come in, any late invoices from any of our subrecipients or contractors, make sure we have accurate numbers for the year. And we've been working very diligently to put these together. I appreciate the finance team working so hard. We're working on wrapping up our annual report so that we can share it with Spokane County. Now that I mentioned last month that the health district is a component unit of Spokane County, so our financial numbers need to be incorporated into Spokane County's, and then we both have our required deadline to file by May 30th. So we're just working all towards those deadlines. So then I'll move on to the March report for 2023. And our revised budget in 22, I just noticed how similar they were. We ended up with a revised budget of $53,182 million in 22, and for 23 we're at $53,338 is our projected 23 budget. And we do have the ARPA from Spokane County incorporated into our budget. I believe that was 1.39 for some improvements to our roof and to the windows. So those are already, they're not part of any assigned reserve, they're part of the 23 budget. We're first quarter for March, and we're running 20% for funding and 20.8, and then expenses at 20%. So we have a little bit of funding in excess of expenses, and that would be specifically related to some of those funding streams that we get paid in advance. We have very few of those, but they are periodic. So for example, Spokane County contributes quarterly $500,000, so we receive that ahead of all the expenses that would have occurred. And then our foundational public health services funding comes in every January and July. So we haven't spent all of those funds yet, which is why we have some more reserve or more funding. And then also in the month of March, you'll notice just at the top, the federal indirect grants and the state grants. Again, we are expense reimbursement based on those. So that'll be reflected in next month's report. Then we'll be billing for those. So most of our funding streams are expense reimbursement, which is why it's important to have those healthy reserves so that we can pay our bills and then get reimbursed. And so moving down to the final reserves at the bottom, with the monthly change, we are at 21% in our unassigned reserves. Of course, maintaining the 1.5 in the committed fund and then our assigned reserves for total reserves of $17,132,000.
Any questions for Kim on our current position? Thank you very much.
Thank you.
So that brings us to our administrative officer report, our deputy AO, Ms. Phillips.
Good afternoon. So the first thing I wanted to do is just say thank you so much to our staff. We had a very successful National Public Health Week, and in the process, we were able to get these beautiful pins. They're, I think they're magnetic, and there's one for each of you, so enjoy. And then the second piece is, we always, each year, provide a work plan for for each department. So I wanted to just kind of give a highlight for all of the department work plans that have been submitted that we've reviewed, and these have also been shared with the staff during the staff forum. So administration is going to be working on an outline for a strategic plan. We wouldn't move forward with Sorry, we should zoom in on Mayor Freeman, who's modeling his new pen. We will be working with a policy procedure process. We're also going to be doing an updated hazard assessment. We do that annually, and then biannually we have a risk assessment that administration publishes. Human Resources is actually in the process of implementation for the new HRIS system. That includes payroll, timekeeping, and also has oh my goodness, I just lost my spot. So in addition to payroll and timekeeping, this is also going to have a learning management system for staff, as well as a way to work with our performance documentation. So they will also be rolling out performance management platform and an annual and setting that up in an annual cadence in alignment with the performance module in NeoGov. Finance will be working on balancing and developing the 2024 budget in line with budget timeline parameters. They'll be preparing the agency-wide 2024 fee schedule. They're working also on centralizing agency-wide travel process and bringing that into one staff. We've actually worked to create a platform in our intranet where folks can go and pull their information or actually post for travel requests. And they'll be working with the annual submission of their BARS report as well as their SAO annual report. Treatment Services, who has plenty going on, We'll be reviewing and developing a new curriculum for group therapy for patient engagement and retention to improve patient-specific outcomes driven by patient-identified needs. They're going to be working through an all-agency, state, federal, and payer requirements to complete transition to their new location. In addition to this, they'll be updating all treatment services required policies and procedures, and then develop a compliance plan for audits to include required reports, reporting for all auditing oversight agencies, as well as a survey tool that may be provided by our auditors. Environmental public health plans to be performing mandated services as usual, but also to work on meeting grant deliverables. They're going to review and update website information. They're going to work on a public education for WAC revisions to Food OOS and PFOS. And they're going to be working on program updates and procedures to incorporate the Washington Administrative Code revisions. Disease Prevention and Response is working to build professional development plan for each manager. They're also going to complete performance evaluations for direct reports, develop work plans and logic models for each program. They're working on monitoring compliance with data sharing agreements, and they'll be participating in local and statewide work groups and committees. Our community health program is working on their safety plans for each department. They'll be reviewing their website for accuracy and making sure that it's current. They're also going to be completing revisions and rebranding for the 123 toolkit, educate parents, community leaders, and decision makers about the HOPE model and youth substance use, and changes to help decrease initiation and use. Collaboration with jurisdictions and community groups to improve the built environment and its impacts, and then also they will be establishing a child health death review process and implementation. PIO and Government Affairs is working on expanding the government affairs public health work or public health policy work with regular communication elements, active involvement at legislature and local government, and create internal policy to address process. They'll be working on finalizing their policy agenda for 2023. They're also working on updating the risk and emergency communications plan to include extreme heat messaging. Successful collaboration with Gonzaga University for a community-wide extreme heat campaign, and they'll be utilizing media relationships for promotional purposes outside of reactive response and breaking news. In addition to these, they'll be working with the program managers to plan out campaigns for 2023, including a vaccination campaign, transition of treatment services to the new location, and they will be working to develop and grow SRHD video capabilities and our library. Any questions about all of those plans?
Any questions?
All right. Thank you.
Thank you, Lola. Appreciate it. And that brings us to our health officer report. Dr. V.
Good afternoon, everyone. So I'm going to go through a number of topics, and some of them are going to be a little bit of a recap or a review, so I won't spend a lot of time on them, but I wanted to give you perspective on a number of things that we've been following over the past few months. We'll talk a little bit about where we are with COVID, particularly as it pertains to the new vaccine recommendations. I'll give you an update on Marburg and avian, one of the reasons why the egg prices have gone up, that we have some additional information, and then highlight some of the activities of the team as we enter into spring and move into other phases of public health. So first thing is, let's talk about COVID, because a question I get asked all the time is the pandemic is over, and the answer is no. There's two reasons for it. Reason number one, you still have infection on a global level, and reason number two, we have not seen the seasonality that allows us for it to be a predictable disease such as the flu. So we're still in a pandemic. That's why the definition is there. But when we get closer to home, this is Western Washington. This is Eastern Washington, and this is actually a 7-day case rate. This big peak is when Omicron first made appearance in the U.S. And if you look at Western and Eastern Washington in aggregate, they're kind of like very similar, about 31, 32 cases per 100,000 7-day rate. When you look down here at Spokane, we're about a 50 plus. Now, this is not uncommon. We have had a rate that is slightly higher than the aggregated Eastern Washington, and Eastern Washington, interesting enough, has usually had an aggregated rate that is higher than Western Washington, but has come down, which that basically tells us, if you look at this baseline, we've never gone down to zero, which says disease is still present in the community. And we do know that because we see that, we all know someone that has tested positive or has been symptomatic in the last few weeks. But this is where we're at. The good news is we don't see any significant spikes. It's more of a slow and steady trend and plateau, which makes it a little bit more manageable from a variety of perspectives, including hospitalizations. When you look at the wastewater, and these are the two facilities that aggregate over 400,000 households, we do see basically a downward trend. Although if you look at the detail, it's up and down, spiky, so we're calling this a plateau. As you know, we're one of the first communities that did wastewater surveillance. And as I mentioned in the previous board meeting, we're looking at doing a pilot on a community level wastewater surveillance, which will bring us up another level beyond what other communities can do or have been doing. Now, we have made the comment before that with Omicron, it's never a single sublineage subvariant that dominates. It's usually the family, so we have multiple members of the family, although the one that has been around the longest is this one. But I want to call your attention to the bottom of this graph over here, this eggplant type color, or deeper purple, whatever that color we call. And this is actually the newer sublineage that we've been following for some time, which is the XBB.1.16, also known as Arcturus. And as for those of you that are fans of astronomy, Arcturus is the 5th largest, brightest star in the northern hemisphere. Anyway, has nothing to do with that. It's just that we're running out of names, and that seemed like a good thing to do. But the reason why we're focusing on that one is we've seen a lot of cases go up in other parts of the world, and now it's about 9% of total cases in the U.S. And one of the things that we know about it is, first, similar to previous Omicron sublineages, it kind of evades post-infection immunity, which we've seen that. And it tends to evade the normal immune response that we do have, even post-vaccine immune response, probably a little bit better than some of the previous ones. But that has been consistent with every new sublineage of Omicron. The next one is always smarter, slightly smarter, even if it's just by a little bit. Now, one of the concerns is, and this is some recently published data, that it seems that it's also not that immune to the current therapeutics that we have in terms of monoclonal antibodies. And as you know, one of the big advantages of this time as compared to 3 years ago is we have vaccines, we have treatments, but some of these treatments are not being as effective with this particular sublineage. Now, the good news, it remains for those that do not have pre-existing conditions and other risk factors, it does remain more of a mild disease, like a bad cold, or a cold of some sort. Now, this one has a new symptom that we have not seen before in other COVID-19 strains, which is pink eye. People are presenting with a pink eye, particularly children. As you know, pink eye is an infection of the eyes that's usually the bacterial or viruses. As you know, viruses, like, it's not that uncommon in children. So something to be aware of, because it's not something that we had seen before, and is a result of this particular sublineage, not any of the other ones. So when you look at the IHME projections, which we've been kind of tracking, you can tell that, yeah, we plateau, but it never goes down to zero like we've done before. So the lesson there is going to stay with us. And good news, as I mentioned, is now we have a lot more knowledge and tools, particularly vaccines, that are still highly effective. So with that, let's move on to the vaccine recommendations. On April the 19th, the Advisory Committee on Immunization Practices from the CDC met, and the goal was to simplify the kind of product salad that we have right now and make a determination as to what are the recommendations on a go-forward basis. And the bottom line is that recommendation was made to allow for an additional bivalent vaccine. Notice I didn't use the word booster, I call it vaccine. And I have a summary of that, for 65 and older, or people that have pre-existing conditions or are immunocompromised. And we'll talk about children a little bit, but basically the biggest issue is that for young children, there's a recommendation that multiple doses may be recommended for children based on age and vaccination history. So that's something that pediatricians are going to have to think and look at a little bit more closely. And this is just a summary. If you actually go to the CDC website, you'll see a very specific and detailed summary. But a couple of points that are important is the FDA removed the authorization of the monovalent, the original mRNA vaccine. Not because they're not good, but because now we have a bivalent vaccine, which is much more specific. Monovalent was the original strain of the virus. Bivalent has ancestral strains and newer strains. That's why it's better. And we do that all the time with the flu shot. We modify the flu shot every year based on what the strains are. So that's not an uncommon issue. One of the goals is also to harmonize all of these formulations, including the way that they're packaged. So if you think about it, this is kind of what we have right now, and you can actually see that many of the vials are even similar in color. One of the things we try to do with medication is make sure that everything is very obvious. You never want medication in which the little vials look the same, because when people are busy, that's when human errors happen. So you try to minimize that by not doing that. So what we're going to end up is with the mRNA vaccines with this too. Okay? That eliminates the look-alike vials for both Moderna and Pfizer, which are the two most commonly utilized vaccines that we have, instead of 11 different vials all over the place. Okay? So age 65 and older immunocompromised can get an additional bivalent vaccine, regardless of when they got the previous one. And the monovalent vaccines will not be recommended in the U.S. And we say the U.S. specifically because it may still be a recommendation in other parts of the world, which is important when you're doing international travel, like we just did, because they do specify what do you need to have in order to travel to other parts of the world. All right. So we do continue to recommend that 6 years and older receive an updated bivalent vaccine. And remember, Pfizer and Moderna have 1 year difference. Pfizer goes down to 5. Moderna stays at 6 years of age. That's why we have that. And this is where pediatricians are going to have to consult based on risk of the child. Like, how many doses do we need to use? So one of the questions that I get asked all the time is, so does that mean we're going to have to get a shot every year? Well, one of the recommendations that we have from the CDC's Advisory Committee on Immunization Practices is more than likely we will see a seasonal, at this point, bivalent vaccine become the way we manage this as we go forward, with the caveat that if you look at the various peaks, we've never had the predictability of going up in the fall or going up in the spring or going up in the winter. COVID has gone up almost every month depending on which new strain is available. And that's why it's a little bit less predictable. But we do know that when respiratory illness season comes along, we have the flu, RSV, COVID, and now we have metapneumovirus too, which is its presence known all over, including Spokane. So let's talk about Marburg virus, which is one of the hemorrhagic fevers. And the reason why we're talking about it is the CDC released a travel advisory health alert at the beginning of this month, because we do have an outbreak every 3 to 4, 5 years, typically one site in the world. Now we actually have 2 unrelated outbreaks. in 2 parts of a continent, which is something we have not seen before. And we have not been able to establish any relationship between the two with travel or anything along those lines. So this is Marburg, and I just happened to like that picture. This is the virus, this is the way it looks, and this little fellow here is the reservoir for that, which is Rosetus aegypticus, also known as the Egyptian fruit bat, although it's not in Egypt. If you think about Marburg, it was first identified in Marburg, Germany. Laboratory workers that were working not with bats, but with monkeys. There's a kind of like symbiotic, there's a relationship here between the bats and the fruit they eat, and then the monkeys. That's how the monkeys ended up with it. But this is the reservoir for the virus, which is a cave bat, basically. Now, a lot of people say, so is it the same as Ebola? And the answer is no. They have a lot of similarities in terms of, well, Ebola, we're not sure where it hides. But they have a lot of similarities in terms of how long it takes for the incubation period, for example. Some of the symptoms, although some of these, particularly the GI symptoms here, can be a lot more severe. They have significant fatality rates, fairly high. Biggest difference is we do have a vaccine and treatment for Ebola. We don't have a vaccine or treatment for Marburg. It's just supportive treatment for symptoms. One of the questions that people also ask is how early are people infections with Marburg and or Ebola, which is actually the same. People are not infectious until they become symptomatic. So the issue of pre-symptomatic transmission is not a concern with either one of them at this point in time. Okay. Now, good news is if you look at in the state of Washington, if we were to have patients, where could they go? This is where where did it go? Right here. Our Sacred Heart Medical Center, it hits that line, and the reason for that is, if you recall, we have the special pathogens unit, which is one of the few around the country, and actually only the second one. There's one of 2 in the West Coast. The other one's in California. So we can handle Marburg, Ebola, and pretty much everything else. And we actually just did exercise with 2 quote-unquote Ebola patients that were in Spokane, which I'll show you the results probably in the next meeting. So let's talk about the avian flu, which, as you know, we've been going through an epidemic for quite some time. As a reminder, basically wild waterfowl that infects chickens and turkeys and a whole bunch of other things that people tend to grow. We have had to either, because of infection or because of being euthanized, lost about 59 million birds in the U.S., which is the reason why egg prices went sky high, because we got almost 60 million less chickens. Although these are not all chickens, but it impacted a lot of chickens. We only have 1 case reported in the U.S. of transmission to a human. I'll show you some detail on that. And actually, this changed as of yesterday in all 50 states. If you look at our neighborhood, this is kind of like how it is clustering. And if you look at some of the detail around the country, this is the bulk of the cases. And as you can tell, we see some really high numbers in places like Florida and California and Oregon, et cetera, et cetera, et cetera. So by now, it's been identified in all states, including Spokane. One of the concerns is interspecies transmission. We have seen this crossover to mammalians of all sorts, whether it's raccoons or others. Actually, in Spain, they had a mink farm that had a little bit of an outbreak. And the cases in Spokane were actually raccoons, although we've seen other types of animals where it has jumped species. And the reason why jumping species is of concern is because we always worry about, is it learning how to go to other species? And we do share a lot of similarities with other mammals. So it's always that concern about that jump from species to species. So these are the human cases that we've seen. The 2 newest ones are in Cambodia. One is a child, the other one's an adult. One died and one didn't. And the one in the U.S. was last year in April, a worker from one of the poultry farms. Basically just didn't feel that great, and that was about it. So we were lucky that we did not see any more. And actually, I don't know if you've seen, I'm not going to mention the network, but there's a network that has specials on poultry farms. It's quite fascinating. You should take a look at it. Anyway, so with that, we're going to move on to some of the activities of the team, because one of my goals is to make sure that we do stay on top of what else are we doing, in addition to COVID and all these other things that we talk about. So we're going to talk about food a little bit. Food is extremely important. Spokane is becoming a foodie empire, so I think it's good to have that. But this is our team that put together it was actually, I think, in the last week or so, a temporary food establishment training, and then we're going to talk about the donated food distributing organization, which is happening today. And there's a difference between the two. So this is the team, and we have Allison and Amy. Allison is on the right, who was the lead on that. And we did something a little bit different in terms of distributing the invitations as we've done in the years before. We use our usual distribution list, but we also took advantage of the distribution list of Greater Spokane Incorporated, SEMBA, which is this Spokane small business, is basically the Small Business Metropolitan Business Association, typically tiny places with one or two of the moms and pop shops. And we also distribute it through United Way, because a lot of the nonprofits do temporary food projects and events. So we had it didn't like me. So we're signed out, but when we get back, so not only did we have the training, and I'm going to show you, we invited, which is added value for those that came, we invited all of the agencies that have anything to do with food, whether it's labor and industry, Department of Agriculture, the Alcohol and Cannabis Board, et cetera. So they were all virtually here. So when people came, they actually got the information on everything. Not piecemeal, not just one piece, not just what we do, but what is required by everybody. And that's part of that value proposition of we'll provide you with all, it's all inclusive. You don't have to go 27 places. You just come to our place and we'll give you everything you want. Oh, The Exorcist, wow. I haven't seen that one in a while. Hello, and welcome back. And as you notice on that table, we also had information that people could take with them, put together a binder with everything that they will need for meeting all of the requirements, all of the criteria, not only from us, but from all the other agencies. And as we get back, maybe, in here, Allison and Amy, there you go. Okay, thank
Oops.
you. Going back to the beginning?
It did.
Okay. So how would you rate your experience with the product thus far? I'm not sure that I would give it a very high rating right now. There you go. Perfect, thank you. Awesome. So anyway, this is a little bit of a highlight of what they did, but we also took the opportunity to include information about petting zoos, because many times these temporary food establishment events, some of them may have a petting zoo. Petting zoos are very common in this region, so we made sure that we got both, just to make sure they had everything. And these folks participated virtually so we could provide to our participants all the information. We are doing today a donated food distributing organization seminar, which is a virtual seminar. For example, our track, the Trent Shelter, is a donated food distributing organization. So is the Salvation Army, there's a lot of organizations that fall in there, and they're exempted from some of the equipment requirements because they don't have the full kitchens and so on and so forth. But there's a lot of things that are still recommended, and we have spent a fair amount of time with our donated food distributing organizations in town, making sure that they're handling food the safest way possible, regardless of who they are. It could be something as small as the Campbell House at some event where they had cookies, or something as big as the Trent Shelter that has hundreds of meals. So it doesn't really matter. We're there to provide guidance to any size activity that is handling food. So it's getting to be summer eventually, one of these days, and our pool operator training team is here, Julie and the team, and this Tricia, Sarah, Tonya, and Sandy. Actually, Julie and Sandy spend a lot of time with us on the education side, not because of pools, but because of all the things that they do. And they're both walking encyclopedias of knowledge. So it's very good people to have. Julie actually has helped us with a lot of stuff, and I think there's nothing that you ask Sandy that she doesn't know about. And she can actually quote you the actual article and the statement, and very, very knowledgeable. So why is that important? Well, because there's a whole bunch of pools and spas in Spokane that are open to the public. And it's important that we prevent not only illness, but injury. As I mentioned the last time, when you look at jungle gyms, members of another team that is part of environmental public health, they're the ones that actually go and ensure the safety of those, including can a 2-year-old's head fit through these slats on this jungle gym. And they have a tool to actually measure that, to make sure we don't put a kit through it, we just have a tool that does that. Although, some people will say, well. But we look at everything from the construction all the way to what we're doing and how you're doing it, including all of the chemicals, water testing, and so on and so forth. And this year we included one additional value add element, which is this self-assessment checklist. So with the self-assessment checklist, you, the pool operator, spa operator, whatever you're doing, you can actually prepare for opening, you can spot check things throughout the year, and you can get ready for inspection. We do that in healthcare. There's pre-inspection checklists that people can use in healthcare to get ready, so you don't have to wait for the inspector to show up and know exactly what all the details are. So we have provided that electronically to all participants, plus we're going to provide that to all pool operators. We also had our friend Ted per year from, and this is not a commercial, from Pool World, that did a troubleshooting with Ted, being the fact that he's a certified pool operator and instructor. So basically, a community member is one of the things that we're doing. We always try to bring community members that have unique expertise to participate in these processes. And with that, we're going to talk about SHAPE, which, if you remember, the acronym way at the beginning is a very long acronym, which I can never remember, but it's about promoting and enhancing. And what we did is bring together public health and healthcare to address issues that maybe are not as big as COVID, but still a community issue, and is an issue that none of us on our own can address. So we actually convened this group several months ago, and it's being led by one of our public health nurses, and the goal was to identify one or two, typically, no more than 3, issues that we as a community are going to address. So we have identified 2 areas, hepatitis C and syphilis. And some of these names are probably names you've seen before. Kira is facilitating that. She's our public health nurse. Mark is our program manager. And then you have the rest of the team. Mackenzie wrote that, authored that hepatitis C article with me for the Spokane County Medical Society. And Kristen co-authored that syphilis article for the Spokane County Medical Society. And the reason why we're working on this too is because hepatitis C is actually one of the few viral diseases that is treatable and curable. And if you don't treat it and cure it, you can end up with chronic hepatic failure and or liver cancer. The good news is we can treat it if we can diagnose it and early enough, and more importantly, prevent it. It's actually, if you look at JAMA this week, National Hepatitis C Elimination Program in the United States, a historic opportunity. So it's actually something that we can do. Mackenzie is our subject matter expert in hepatitis C. Help with some of these names you've seen before. And on syphilis, the main issue that we have in Spokane, our rates have been higher than the rest of the state. And unfortunately, we're seeing heterosexual transmission increase. So we have a concerted effort with our healthcare partners for education, detection, and treatment. It gets particularly complicated when you have things like neurosyphilis. The reason for that is because the very few, it's intensive treatment, and whether you put the patient who's responsible for it. So there's a lot of logistical issues that we're trying to address with our healthcare partners, with the help of our healthcare partners. And this is the model of convening that we're using more and more and more to make sure that it's not only about what we can do, but it's about we as a community can do, which is a lot more than we can do on our own. So with that, I'm going to stop here and see if there are any questions.
Questions for Dr. V? That was informative. Any final comments, Dr. V?
No, thank you. And I just want to say thank you for the team for everything they're doing, because they're busy and we have a whole bunch of people participating on that training today as we speak. I can tell you a lot more detail about any of these, but I'm sure that you're okay with what I say.
We'll take it as face value. Thank you.
Thank you.
Thank you very much. So that concludes our reports for today. That brings us to board member check-in. Dr. Polakani had a pre-standing appointment, so she departed during our reports. I will ask Commissioner Kearns, do you have any comments or anything you wish for the good of the order?
No, not today.
Thank you very much. Mr. Durama?
Not today.
Mr. Patterson?
None for me.
So with no comments from our board members, and I have definitely talked enough, I would look for a motion to adjourn, or actually, do I? Yeah. A motion to adjourn at 2:09 p.m.
I move to adjourn.
Second?
Second.
All in favor?
In favor. Aye.
Then we are adjourned. Thank you all very much.